Hello everyone and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinions and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Saba Balasubramanian, Adam Haig, Ben Wood and Josh Lau, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
Right, so we'll talk about measures of risk, the final part. So for those of you who have not come across the earlier versions, they're all there on the website and on YouTube. It might be worth your while looking through parts 1 to 3, because we're going to skip over the basic concepts and go on straight to time to event data. Right. A couple of slides on what we learned before in parts 1 to 3. We talked about odds ratios, relative risks, and attributable risks as commonly used measures of risk. We talked then about relative risk reductions, absolute risk reduction, and number needed to treat. And we then moved on to time to event data. So when we talk about time to event data, we mean not just the event happening. So we're interested in not only whether a specific event that we're interested in happens or doesn't happen, like for example, death, or a wound infection, or a recurrence of a hernia, for example. But we're also interested in when that event happens. Does it happen early on during the course of follow-up, or does it take many, many years? Because obviously that's important. That's quite important as well, as you can imagine. We, in the last part, talked about what hazard ratio means. Hazard ratio is a risk measure used for time to event data. It's very, very similar conceptually to relative risk, and it compares time to event data in two groups. So we're now going to move on to talking a little bit more about time to event data. So let's just take survival as an example, which is essentially whether somebody has survived a particular sort of disease or not. So how can we describe survival? We can either describe survival as a percentage of patients surviving at a specific time period. So you could say following treatment of, let's say, colorectal cancer, 90% survived at 1 year. You could say 74% survived at 3 years, or you could say even smaller percentage survived at 5 or 10 years. And that's a useful way of depicting to clinicians and to patients, what the survival chances are. You could also look at survival slightly differently, and you could say, 50% of the patients in your cohort lived for up to 6 years. So there you're talking about median survival. And again, you could say what the lower quartile was or the upper quartile was, or you could say 90% of patients survived X number of years. So there are these different ways of talking about survival. So you're talking about survival at a specific time period, or you're talking about the number of years a particular proportion of your cohort survived. To describe or present all of the above, we use a survival curve. So we'll talk about survival curves in the next 2 slides. Right, so here is a typical survival curve. This is a Kaplan-Meier survival curve. I've got this data from my PhD from many, many years ago. You've got the survival of patients with grade 3 breast cancer plotted on this graph. So on the x-axis, you have time to a specific endpoint. Here, this is death or metastasis in months. And on the y-axis, you have the probability of people surviving. So right at the top here, and I'll try and show you here, right at the top, at the beginning of the study, if you like, you have all of your patients being alive. And then as time goes on, you have patients dying or developing metastasis over time, and the y-axis gives you the probability of surviving at a particular time point. Okay, so there are lots of YouTube tutorials on how to create a survival curve, and also explanations on how you interpret survival curves in a lot more detail than we have time for. So I'll try and give you a bird's eye view of what we ought to sort of learn about survival curves. So these curves show proportion surviving without the event happening over time, just like I explained. And you've got to keep in mind that the event does not have to be death. So a survival curve could be anything. It could be occurrence of a hernia, for example, or reoccurrence of a hernia after repair, for example. But they're all called survival curves. All of these time to event data are typically called survival curves. And sometimes the event can be a composite event, like either death or metastasis. So any event that you're particularly interested in, and it doesn't necessarily have to be death. Survival curves usually take what we call censoring into account. So what's censoring? And you probably have heard this word in the context of survival analysis. So censoring occurs when a patient drops out of the study for a number of reasons. The patient could have left your area and migrated to another country or another region, and you don't have any data. So that date of migration or moving away from the area is taken as a date at which you censor the patient, which means that you accept that you do not have data beyond that point in time, and you know that at that point in time they have not had the event. Another example of censoring could be if you're looking at a patient who's died of, say, a road traffic accident after being enrolled in your study for a specific treatment for grade 3 breast cancer, and you have said that you're only interested in events that are directly related to breast cancer, or in other words, deaths from breast cancer, and if they've died of a road traffic accident, then you, at that point in time, say that they are censored. So that would be another good example of censoring. A third example of censoring would be that if you have done a study over a 10-year period and you have recruited a patient in year 9, and then you've got just 1 year of follow-up, and you completed your study, and that at 1 year the patient obviously is still alive, and you do not have data beyond the year because you're stopping the study, then again at 1 year that patient would be considered to have been censored. So a number of reasons why censoring can occur. Now, survival data is usually presented using non-parametric methods, and the reason for this is that you do not need to make any assumptions about the distribution of the survival times. So you may know that for some diseases the survival in the first few years after the occurrence of the disease might be low, in that many patients might die very early, and then once they've survived beyond a certain point, then their chances of continuing to survive goes up. And in other diseases it might be the other way around. So if you employ non-parametric methods, then you don't have to make any assumptions about how the survival is distributed or how the events are distributed over time. So that's a kind of typical sort of conventional thing to do, describe survival using non-parametric methods. And there are a couple of important assumptions that you've got to keep in mind when you're looking at the survival curve. The first is that the censoring is independent of the event. So patients migrating or dying of other causes, those events should be independent of the event of interest, i.e. dying of breast cancer or getting metastasis from breast cancer. The other important assumption is that the probability of survival is independent of the start times. And this is very important and often not clearly understood. So what I mean by this is that if you're including patients in your breast cancer study, for example, for over 10 years, then you've got to make the assumption that patients getting enrolled into your study in the first 2-3 years, their prognosis, their survival is the same as patients getting into your study in the last few years of the study. Because if treatments have changed dramatically during your study and the prognosis changes dramatically because of changes in treatment, then you really shouldn't be looking at the survival of this entire cohort accrued over 10 years. I hope that makes sense. If not, come back to me during questions and I'll explain this again. Right. So that's the Kaplan-Meier survival curve again in a cohort of grade 3 breast cancer patients. So that's the same curve that we've seen. You've got to keep in mind that there is another type of survival curve called the actuarial survival curve. Now, in Kaplan-Meier survival curves, each time an event happens, you plot or you calculate the cumulative survival. So let's say you got a couple of deaths occurring in a very short interval of time. At that point, you calculate your cumulative survival. And then you carry on, and then when a death occurs again, you calculate your cumulative survival again. So each time an event happens, you work out the probabilities and you plot them on the graph. Well, you don't do them physically. You have lots of different software that can do this for you. Contrast this to an actuarial survival curve. Here what happens, you've got this actuarial survival curve on the same cohort of patients plotted on the graph on the top right of your screen. Here the cumulative survival, or the probability of you surviving, is plotted or is calculated at specific time intervals. In this particular graph, we've done this every year. So every year you calculate what the cumulative survival is, and then you go on for another year and then calculate what the cumulative survival is. So the main difference between what we call actuarial survival curves and the Kaplan-Meier survival curves is this. In the actuarial survival curve, you plot the probability at fixed and regular time intervals. In the Kaplan-Meier survival curve, you plot the survival each time an event happens. Now, the good news is that in most of medical literature, we use Kaplan-Meier survival curves. But I thought it is important for you to just keep in mind that you can plot survival curves in two different ways. Okay, now let's just move on to something that I think is probably a little bit more interesting. So not all survivals are the same. What do I mean by this? Now, when you're plotting a survival curve and you're talking of survival, median survival, and what have you, you've got to be careful about what you mean by the event of interest, and you've got to define it very clearly. So when you say survival and death, you have to understand what you mean by survival or death. You might find that strange, but what I'm trying to say is you've got to talk about if death is your event, you've got to look into what is the cause of death, whether you're interested in death from any cause or whether you're interested in death from the specific disease you're interested in. You then have to decide a priori when to censor and decide on what events to ignore. Now, if you take the example of, say, colorectal cancer, and I've shown you this little table here. It might appear a little bit complicated, but I'll explain this table. You can see that survival can be defined in a number of different ways. And this table has been derived from, has been extracted from a systematic review that looked at how survival was defined in a number of colorectal cancer trials. And you can see here that they have on this in this table at least 6 different ways in which survival has been defined. So let's just look at a couple of them and then hopefully it'll make sense. So OS stands for overall survival, and here the endpoint is death from any cause. So if there's death from the same cancer or from another cancer, or there's a non-cancer related death or a treatment related death, you consider that as an event. So it doesn't matter what they died of. If they've died, that's an event. If they just had disease recurrences or they had a second cancer, then they're all to be ignored. Those events are to be ignored completely. Obviously, there's loss to follow up, then you censor them. So if you are interested in overall survival as your endpoint, then this is how you define your events of interest, you decide when to censor, and you decide what to ignore. Another example at the other end of the scale is what we call disease-free survival, DFS. You've probably come across this in on a number of occasions. Here, disease-free survival means that you're interested in either death from any cause or recurrence of the disease or recurrence of the colorectal problem. So if you had recurrence or distant metastasis or a second colorectal primary, or if you've died from colorectal cancer or any other death, you are interested in it and you classify that as an event of interest. If you lost a follow-up, then you're censored, and you're not really ignoring any death from any cause or whatever recurrence related to the cancer happens. You're not going to ignore anything. So you can see how disease-free survival and overall survival differ. And then if you're interested, if you have time, you can come back and look at what recurrence-free survival is, time to recurrence, time to treatment failure, and cancer-specific survival are. Now, I'm generally interested in cancer-specific survival as an endpoint, and also sometimes in disease-free survival. And they are actually quite different. A lot of people assume that disease-free survival and disease-specific survival are very similar, but actually they're not. So if you have time, you come back and look at this chart, and you will find that the events of interest, the censoring, and the events that are ignored are quite different between disease-free survival and disease-specific survival. Okay, so why does this matter? Now, let's just take these two extreme examples, overall survival and then disease-free or disease-specific survival. Now, clearly, overall survival is going to be influenced not just by the treatment of the cancer, but also by other factors such as toxicity, and chemotherapy toxicity, for example, associated morbidity, and age. Whereas disease-free survival or disease-specific survival is going to give you a more accurate reflection of the efficacy or effectiveness of the treatment. So that's an important difference. If you look at objectivity, overall survival, which is essentially saying death from any cause will be an event, is pretty objective, so you can't argue about death or being dead or alive. However, if you look at disease-free survival or disease-specific survival, it is not very objective at all. And this is one area in cancer epidemiology that people tend to get a little bit perplexed. If you say to them that the disease-free survival is not a very objective measure, you might find some eyebrows being raised. But essentially, what you're saying is, depending on how frequently you're going to screen for disease occurrence, let's say colorectal cancer, you've given a specific chemotherapeutic regimen in your cohort of patients, and then you want to follow them up. And if you decide to screen them every 3 months, as opposed to every 2 years, survival, then you might get the numbers you need, and the events happen a little bit sooner, and you could finish the study relatively early. Right, so we come to the learning points. So we talked about time to event data, and we talked about how time to event data is usually best presented as survival curves, as opposed to just saying median survival or X percentage at 5 years or so, and so. Kaplan-Meier curves and actuarial curves are the two ways in which you can present a survival curve. Kaplan-Meier curves are the ones that are commonly used in medical literature. And just remember that in a Kaplan-Meier curve, at every point or time period an event occurs, you calculate your probability of survival. And it's important to think about the endpoint in some detail. How do you define your event? What can be considered non-events, and when would you say censoring occurs? So when you're critiquing a paper with survival data, or if you're doing a study, but if you're conducting a study, it's important to think about these endpoints. And There are a number of different endpoints. I showed you a sample from colorectal cancer literature. There are about 6 or 7 different endpoints. They all have slightly different utilities and are of value in different contexts. Thank you very much.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.